Cancer Center in Chennai now. I'm a consultant radiologist there. I'm fellowship trained breast imaging radiologist. I also take care of the breast cancer and gastrointestinal cancer management teams and interventional radiology. I'm really thrilled to present this study from a very active group in academics and research. The study is titled Prediction of Response to Neoadjuvant Systemic Therapy in Triple-Negative Breast Cancer using baseline tumor MRI characteristics and imaging pattern of response. So let's quickly look at the authors of this study. There are about 29 authors from MD Anderson Cancer Center, Houston, Texas. Most of them hold prominent professors and associate professorships within the group. A lot of them boast over 8,000 citations and more than 50 publications in high-index journals. Of mention, Dr. Alistair Thompson. He's the Professor-in-Chief, Section of Breast Surgery in Baylor College of Medicine. And Dr. Stacy Mulder, of course, she is the Professor and co-leader of Breast Cancer Moonshot at MD Anderson Cancer Center. This is a $2.5 million philanthropically supported research initiative. Her affiliation is also with Eli Lilly pharmaceutical company. So as a background, we all know that triple-negative breast cancer has poor prognosis. In America alone, between 2012 and 2016, over 12% cancers diagnosed were triple-negative. In particular, the triple-negative breast cancers who have significant residual disease at the time of surgery have poor prognosis at the end of completion of neoadjuvant systemic therapy. So this study is an effort to identify patients who are unlikely to achieve pathological complete response. Hence, the authors investigated if pre-treatment breast MRI with morphological characteristics and follow-up MRs that show image response patterns during the NST can predict a pathological complete response in TNBC patients. This is a part of a larger Artemis clinical trial, which stands for a robust triple-negative breast cancer evaluation framework to improve survival. It's a prospective IRB-approved clinical trial. It estimated enrollment of almost 1,000 participants. It started in November 2015, primary completion date of 2021 November, and the study completion date is going to be 2023 November. The arms in intervention included tumor biopsy, the baseline evaluation, IHC, as well as molecular analysis, ultrasound, baseline lymph node evaluation, and the primary outcome measure was the response rate with a time frame of up to 5 years. So this particular study is a subset of 199 patients with biopsy-proven stage 1, 2, and 3 triple-negative breast cancer that received neoadjuvant systemic therapy, and they were classified as PCR, that is pathological complete response, or non-PCR based on histopathology at surgery. The patients underwent breast MRI at baseline after 2 cycles of adriamycin-based chemotherapy. The second follow-up MR was done at 4 cycles of the chemotherapy. So the MRI studies were reviewed by 2 fellowship-trained radiologists who were blinded to the pathology results. The MRI morphological baseline features were based on ACR MRI BI-RADS lexicon that all of us are aware of. The imaging response pattern at C2, that is after 2 cycles, and C4, that is after completion of 4 cycles, were classified as follows. So type 0 was complete response, type 1, as demonstrated in this diagram, was concentric shrinkage, type 2 was a crumble, type 3 involved diffuse enhancement, type 4 was stable appearance of the tumor at the end of 4 cycles, and type 5 was progression. So the MR findings were used as a guide to intervene and change the neoadjuvant systemic therapy, and then these results were summarized and compared to the PCR status on surgical pathology. Fisher's exact test was used, and p-value of less than 0.05 was considered statistically significant. So a little brief about Artemis clinical trial. It offers triple-negative patients personalized therapy, and the way it does that is that at baseline, when the patient has a breast core biopsy, they also run molecular profiling of the tumor. Baseline MR and 2 MRs are done subsequently, and the mid-therapy imaging response pattern deem the tumors either chemosensitive or chemoinsensitive. The chemosensitive tumors continue AC chemotherapy followed by taxane-based neoadjuvant systemic therapy, whereas the chemoinsensitive tumors, the patient is offered opportunity to participate in one of the following 4 randomized single-arm therapeutic clinical trials that are linked to Artemis. So these 4 trials are listed out here. They involve drugs that block androgen receptors, which is seen almost in 15 to 20% of all breast cancers. They're drugs that involve the vascular endothelial growth factor receptor inhibitor, the mTOR inhibitor, the EGFR monoclonal antibody, as well as PD-L1 inhibitor. The interesting part of this study is that it does not waste any time. By the time the molecular profiling results are ready, the patient has already finished the first leg of the therapy and the initial analysis to assess whether the patient has optimally responded or not. So the results of this subset of patients, they were about, the median age was 53 years, age ranged from 24 to 79 years. For 95 patients, that is almost 48% of the patients, had pathological complete response, whereas a slightly larger component, 52%, had non-PCR. So at baseline MRI, it was found that an irregularly shaped mass and homogeneous or clumped non-mass enhancement were associated with pathological complete response, and this was significantly statistically significant, as against a rim enhancement lesion or a circumscribed lesion or clustered ring non-mass enhancement pattern. Multifocality, peritumoral edema, and intratumoral necrosis were independent of the pathological complete response. In the following neoadjuvant therapy assessments with MR, most common MR response pattern was type 1, that means a concentric shrinkage of the tumor, which was seen with equal frequency in PCR and non-PCR at C2 as well as C4. This is a very interesting finding. The following response patterns associations were also found. Type 0 was associated with PCR at both C2 and C4 time points, significant statistically, while 4 and 5, which means a stable and an enlarging mass, were associated with not PCR even at C2. The 4 patterns from the crumble, diffuse enhancement, stability, and progression were associated with non-PCR at C4. The conclusion that was drawn from the study is that baseline MRI tumor morphological characteristics and MR imaging response patterns during NST may be valuable markers for PCR prediction in TNBC. Qualitative breast MR assessments may act as an accessible tool to identify TNBC patients who are unlikely to achieve PCR and may benefit from targeted therapies. There was an interim analysis by the same group, which was done a while ago, that used ultrasound as an imaging tool, and showed an interesting finding that the non-responders, the chemotherapy insensitive tumors who continued to standard chemotherapy and a taxane as a second phase neoadjuvant therapy, none of them had pathological complete response. However, those in the insensitive cohort who enrolled to one of the 4 therapeutic trials linked to Artemis, almost 50% showed pathological complete response. So it will be interesting to wait for 2023 to see the large 1,000 patient data, what results and what long-term overall survival data it produces. Some interesting studies published recently by the same group. And as Dr. Jwala just presented, the responder trial, one of the trials in 2018 was also done for the exceptional responders, where the surgery can be eliminated, and even this group is prospectively enrolling patients for another trial. Thank you.